Hi, it's Dr. Naiman again. We're up to the fifth video in the series. We're going to tackle cohort studies. Um, so when you can't do a randomized study for reasons, cohort analysis is the next best methodological approach. The definition of a cohort is patients that are grouped together somehow by a common exposure. Uh, uh, they can be stratified by risk factors of interest, or they can be stratified by given this medication versus another one. This test was performed on them versus another one. So this is different from a case control study, which we will get into later, which patients are stratified by a common outcome. So that's probably the key uh, to take away from this. And a lot of the analysis is somewhat similar, so it can be very confusing, but it's basically the direction you go in. So the prospective cohort is methodologically more rigorous. And it basically you determine what the at-risk population is. You decide upon what cohorts you are going to study, and then you go ahead and every patient that is of the at-risk population and that will get enrolled into the study and filed into one cohort or another. And then as you're doing that, you measure the rate of the outcome of interest in both cohorts and you compare and contrast. So patients come to the emergency room with an asthma exacerbation, and you can cohort them into smokers or non-smokers. Then you can enroll them, and then you can look at admission versus discharge or ED length of stay, and a whole bunch of other outcomes. Um, a retrospective cohort, not to be confused with a case control study, which is also done retrospectively. But a retrospective cohort, you still essentially go through the same steps. You determine the at-risk population, you divide them into cohorts, and then you review the charts or whatever other data sets you have, and you include patients that meet the criteria for either cohort in the at-risk population. And then once again, you measure the rate of the outcome of interest in both cohorts. Remember, in a case control study, the outcome is the fixed point, and then you're going backwards to see what the exposure rate was in each group. So like just take a moment, kind of firm that up in your head. All right, here's an example of a retrospective cohort. Once again, at-risk population, uh, patients coming to the emergency room with asthma exacerbation. Once again, you're going to break it up into smokers and non-smokers. But this time, instead of enrolling the patients as they walk in through the door, you are just going through their charts and you're trying to see what their outcomes are. Um, so let's compare and contrast. First of all, the validity. Prospective is more reliable when testing an a priori hypothesis. Uh, Now, sometimes you can turn a prospective data set into retrospective if you're going back on already collected data. This falls prey to the same retrospective, but not quite as much, especially if the data is collected in a unified fashion. So retrospective data is a little bit more suspect. You can inadvertently select data that fits your hypothesis. Um, so perspective, like I said, you can collect custom data. You can make sure that it's collected the same way every time. So instead of having to dredge through old charts and figure out where people are recording, is the patient a smoker, trying to figure out, how severe they thought the patient was, you can just put a item on the form. How severe do you think this patient's asthma exacerbation is? And they can do a Likert scale, and it's going to be very unified that way, and you're not going to have to tease it out with fancy adjectives that the doctor is writing in the chart later. When you collect the data, you're almost like you're almost assured that the data is going to be complete because you're right there. You're filling out the prospective data gathering form. So there's no reason that there should be incomplete data. Whereas in retrospective studies, if the data is incomplete, it's gone. And if it's inaccurate, that might even be worse because you don't know that it's gone, but somebody just inadvertently filled out the wrong thing. Such as X-ray text, sorry about that. And then you measure the probability of disease and see who has more cancer. And yes, cancer takes a long time to find, but you'll know the Framingham cardiovascular study, that is a cohort analysis that has been ongoing for I think like 70 years now. And it's a prospective cohort study. They are collecting data in a very standardized fashion, and it makes it a very robust set of data to analyze. And they could probably look for cancer if they wanted to in the Framingham study, and it would be very valid. So here's the 2x2 table, just to, kind of clear it up in your head. The other way you can use it is patients who are being either tested with a new test. It also applies for treatment with a new treatment. It's the math works the same either way. And you compare it to either gold standard or whatever the standard of care treatment is. So if you're testing for MI or PE, you compare the new tests to a gold standard, CT angiography versus test, clinical algorithm versus D-dimer, etc. And here's the resulting 2x2 table. There are problems baked in to cohort analysis. You cannot blind at all. There's no possibility of it. So any outcome that is subjective, it's very difficult to appraise for. If, someone comes into the ER, they're a smoker, they might say that their asthma is worse because they just know they've had bad outcomes with asthma. I don't know. So that could be it. Or they could all say that their symptoms are better because of the ciliary stunning of cigarette smoke. Their asthma symptoms might actually not be as bad, but they are actually clinically much worse. So that's a big problem. Retrospective data points are just psychologically, if you're reviewing data, you want your data to fit your hypothesis. And if you're looking at a retrospective analysis and trying to figure out, does this patient, what kind of outcome does this patient have? Do they fit into your, which cohort do they fit into? You might tip the scales inadvertently that way. Breastfed babies with higher IQ, if the examiner is, this can even be prone to, prospective studies. If an examiner is examining, breastfed babies and knows the baby is breastfed, then it affects how they score the IQ test, perhaps. So, and you could end up telling the, examiner, is, not blinding the examiner to whether the child was breastfed or not. But if the parent is there and knows why you're doing the study, they might go on and on and on about how good breastfeeding was for their baby. So that's, that's going to ruin blinding, and there's no way that you can counteract that. Also, you have to worry about confounding. There could be a hidden confounder that you don't know is affecting your outcome. And this is why we like to randomize studies, because randomization is the only way to counter for hidden confounders. And subgrouping. So yeah, I have no plans for an entire lecture on subgrouping, maybe someday. But in prospective cohorts, it's better to assign subgroups prior to data collection. You can do post collection, but it does, especially if you're doing it in the same study, then it looks like you were fishing for a p-value, and that is considered uh, insufficiently rigorous. If you were taking a previously collected data set and mining it for new data, first of all, that's a retrospective cohort. It's also methodologically just a little bit better, but yes. All right. So, and remember, retrospective cohorts are all post-collection groups. So if you have any questions, if you're taking this course for credit, don't forget to take the quiz. You can email me any questions that you have. And if you're not taking the course for credit, don't hesitate to drop questions down in the comments section.